strangest feeling to know what to believe in.
Hi, my name is Vinita Chandramodi, and I'm the founder of Stroma Physical Therapy and Ischemic Conditioning Techniques, or ICT. I started this practice to have creative flexibility to give my patients the best possible care without constraints. No cookie cutter therapy, personalized, targeted, and effective therapy to get people stronger and better. We don't just teach you what to do, we teach you how to understand your body as you are the captain of your own ship. It's not just about performing an exercise or lifting a leg, but activating the right sequence of muscle patterns to create the optimal effect. At Stroma, we look at how pain and dysfunction influence the whole body, not just the area that hurts. After all, we are a fine-tuned machine. As a manual therapist, I realized that we could influence and treat much more than just a single muscle tissue. So I developed a full body technique that uses mild blood flow restriction to help influence tissue repair. All of our therapists here are trained in the technique. The missing ingredient in most PT is love. We love and are passionate about what we do here at Stroma so that you can become your best self. Come to Stroma so you can move, perform, play, walk, stand, live, heal, and finally feel better. And now I'll take any questions you might have.
Hi, I'm actually just doing a quick interruption here. I'm sure everyone's got great questions for Vinita. I really enjoyed the presentation. I think it's going to give all you students a really good outlook on how to approach your patients. So I'm excited to hear some of your questions. I'm just going to briefly mention that we are looking for research students. We are going to be doing the APTA pelvic grants, which we are wanting to use the PVAS scale. Our patients love it, and we're hoping, one of you students will be interested. You can email me or info@Stroma PT. If anybody's interested, or if you know anybody, that would be great. Any questions?
Okay. So I'm going to go through the chat here. Let me see if I can go. Let me start there. I think that would be a good place. So okay. The first one is, okay, this is from Abid Shah. Urinary incontinence is typically a red flag for a lot of conditions. Are patients who coming to you coming with the assumption that there is no underlying issue that might require further medical attention? The answer is sometimes. But sometimes not. And it's your job to sort of elucidate whether or not that issue is one related to low back pain or, Cauda equina syndrome, so CES. So if you get a prescription for urinary incontinence, you're asking all your good questions. When are you incontinent? Are you rushing to the bathroom? When you turn in a key, there's something called a key in the door trigger. So you have to go to the bathroom and you might not be able to hold it. So part of this is what you're determining on your history as well as assessment. Now, if somebody comes in with severe low back pain and are presenting with urinary incontinence, usually you'll find urinary incontinence in more progressed low back situations. So you're really doing your own, you're kind of looking at this objectively, looking at whether or not you should be triaging your patient to an MD. Is it an emergency situation, or is it something that you are going to take care of in your clinic? It is pretty obvious though, when it's an emergency situation. In situations where it's more subtle, once you start treating and training up, there may be a neurogenic component, and that you need to address the low back as well as the pelvic sling to help improve those functions.
Anita,
Okay.
I just want to interrupt. Maybe you could put the email resources on the slide so that people can have access to those while you're answering questions. Thanks.
Sure, thank you. what does your plan of care look like for somebody with anorgasmia or erectile dysfunction? Well, again, it's like you're taking in all of this information from their subjective and looking at their pelvic floor environment. So in a situation where you might see somebody with anorgasmia, they may have, and in my practice, what I've seen is they've had typically hypertonic situations. So plan of care will look like releasing the structures that you feel are restricted and strengthening those that you feel are weak. And so that's really no different when you think about it than what you would do with somebody with a rotator cuff tear or a hamstring pull. It's really the same basic principles. So once you've assessed and determined the nature of the condition, you're working on for anorgasmia, I would say it's mostly stretch based. I typically have not seen really weak or lax pelvic floors, although it can happen. I just haven't seen it. So you're really just treating what you see. With erectile dysfunction, it's the same thing. That tends to be more vascular in origin. So you're looking at vascular supply, looking at the pelvic sling as well, whether or not there's hypertonicity or hypotonicity. And treating what you see. For men, you treat it rectally or externally. And sometimes I will say that your pelvic sessions aren't necessarily always behind closed doors. You're not always just treating the pelvic floor. Sometimes you're just treating maybe it might be their posture, maybe it might be their breathing, it might be their foot mechanics. So it's not like you always have to do pelvic floor therapy to treat the pelvic patient. Okay, I'm going to keep going here. Questions keep coming in. Can you elaborate more specifically on how pelvic floor connects to the labrum? How would you explain this connection to your patients? Well, I don't have my pelvic model, but the obturator internus actually directly inserts on the tendinous arch of the levator ani. And so if you look at the anatomy, you will see a real direct correlation between fascial tension patterns that might exist between the obturator internus as well as the levator ani. So if you, as I mentioned before, I was kind of highlighting the mechanical effects of pelvic floor tension, that tension can put the pelvis on an anterior tip, causing the obturator internus, which fascially connects into it, to tighten as well and externally rotate the hips. Well, if the hips are externally rotated, that's going to put naturally more anterior shear force on the acetabulum as at the hip joint, which can increase the risk of FAIs as well as labral tears. I hope did that make sense? A lot of mechanics. Okay. If someone has foot pain and excess motion in the transverse plane, how do you determine if this is due to pelvic floor weakness, and how could you treat this? This is like an awesome question because it's not easy to see this. It's not necessarily what you're looking at. But if somebody comes in with excessive transverse plane motions, they're pronating, this is where the PVAS might be really helpful. So you don't want to necessarily address that there's pelvic issues. You might start to ask questions like, oh, you have a lot of laxity. Do you have laxity other places? Are you, do you have any low back pain? Do you have anything related to your urinary or bowel issues? So then you start asking more questions, and answers that come through start helping you direct the questioning towards that pelvic floor. So I love the PVAS for this reason. Now, if you could just give them the PVAS and they could answer the question, already you're determining whether they themselves can even activate or not, or release. And if you find that, then as a non-pelvic practitioner, you'll be able to say, okay, maybe we need to activate. Maybe you need to pull up a little bit and squeeze between your pubic bone and your anus. And there's some instructions on the PVAS that I give you on how to instruct your patient. And so if that helps boost them, or you see a correlation or an improvement in their MLA, for instance, with a pelvic activation, put them on a BOSU and see if that improves their ability to stabilize. that can all contribute to whether or not there's a mechanical relationship there. So you treat what you see, you treat the excessive transverse plane motion, but if you can boost them in the other environment, why wouldn't you just do that in the moment? Because it might help them in the end. Okay, I'm at the end of questions. Anybody want to talk about it verbally, or you can continue to use the chat?
Yes, feel free to unmute your mic and speak any questions that you have, as well as put things in the chat.
So I can
Hi,
talk
Vanita.
to.
This is.
Oh yeah, go ahead. Go ahead.
Sorry, this is Chloe.
Hi, Chloe.
Interestingly enough, hey, I ran into a lady at a conference, and she was telling me how a pelvic floor PT had helped her during her time of pregnancy. So I was just wondering if you ever treated and or dealt with pregnant females, and like exactly how you treat them, and like what do you do? Because she said she was having a lot of pain. She thought it was just part of the pregnancy, but it wasn't. So then she went, and I don't know if she didn't really go into details, but I don't know what they corrected per se, but I just wanted to know more about that, because I thought that was pretty interesting. So I would never think to go to a pelvic floor PT during pregnancy.
Yeah, I have a lot of women who are pregnant that will seek out pelvic floor PT in anticipation for issues that might turn up in the 4th trimester, which is the first 3 months of a child's life, because women it still feels, they call it the 4th trimester because it feels like you're still pregnant, even though you're not, but you're dealing with some of the effects of pregnancy. It's a really good question. So what I say is, if you have a referral for pelvic floor PT from a physician that suggests pelvic PT, to me, every practitioner is going to find their comfort zone with this. For me, I don't introduce digital exams into a pregnant woman's vaginal environment for risk. But and I don't do internal work for women that are pregnant, but there are so many other things that can be done. Not to say that you can't do it, you can. I just make that personal choice. I do other things because I think there are many other things that you can do to improve pelvic tension without having to go internally. So I'm not sure what this patient may have faced, but as a practitioner of this area and of pregnancy, I would do a lot of things that, I draw on my other ortho skills. So I'd be doing a lot of lumbosacral stabilization, deep breathing, stretching, teaching positioning. I do external fascial work on the labia, the hood, the vestibule. So there's a lot of other techniques that can be done without having to insert. But is it possible? Yes. It's not my choice or not my decision that I do that.
Cool. Thank you so much.
Such a good question, Amelia, I did not talk about sexual trauma at all. I talked a lot about psych. So in my coursework, and my coursework has changed. So I've been in coursework for pelvic PT for 12 years, probably 12 years. And at the beginning of my coursework, there was a lot of skills to have the so often, to answer your question directly, during internal exams, I'm always describing what I'm doing before I'm going to do it. So it prepares the patient. I'm using words, I'm using soft words. I'm being very, very deliberate on every single thing that my best tool in the pelvic floor room, my finger, does prior to doing it. I do that with everybody. So it is not just with a sexually traumatized individual. But at the beginning of my coursework, we were kind of taught to approach a digital exam as a part of therapy for people that have suffered from trauma. And more recently, there has been a focus on something called sensate focused therapy, which is really a non-internal touch-based approach to dealing with trauma. So you start with like inanimate objects and touching a patient in a variety of positions. And so you don't have to do an internal exam as a part of your initial evaluation. There's nowhere that says that in the coursework that this must be done. It doesn't have to be done. It doesn't have to be undone on the first session. It doesn't have to be done on the third session. At some point, the whole point for them to be there is to get over the trauma, or to have better sexual, urinary, or digestive function. So you have a purpose, but it doesn't have to happen on the first session. And it's really based, you have to put the power into your patient's hands in a situation like this. And so it is delicate. It takes a lot of time to learn how to do that. With good coaching, you can get there. But yeah, you don't have to do it on the first session. And there's other approaches, other non-internal approaches to helping PTs, to helping patients. What I learned about from COVID, actually, I hate to say the COVID word, but what I learned about COVID is when your hands are tied and you have to do telehealth sessions with patients, what I was so blown away by, because I'm such a strong manual therapist, is when my hands were tied, I was still really effective. I was shocked by that, because